So we're going to continue our discussion now and start talking about some of the cancers of the female reproductive system. And we are going to spend some time on cervical, ovarian, and breast cancer in terms of the main cancers that we're highlighting under this category. So this audio will just have cervical cancer, and then I'll tackle ovarian cancer in a separate slide just so that I don't go over time. So in terms of this area, so this is probably the least area that I have a lot of experience in. I never really worked with patients that had cervical, ovarian, or breast cancer in terms of my clinical experience. So for these PowerPoints for cervical and ovarian, for sure, there's some notes that are included in there. So I think Professor Ng had these notes from before, and then Professor Summers tweaked them a little bit more. So I just kind of included them here for you. I generally try not to give you too many notes. Like I like to just highlight exactly what I want you to know, because I feel like there's always too much information, and then sometimes you get overwhelmed. But for this particular audio, do read some of the notes that are included just to get a better sense of what's happening with these types of patients. And as usual, I'm going to keep highlighting whatever I think is the most important as I go along. And so if it's on the slide, it's something that I really would like you to know. And then the notes will just kind of support some of the information. And for here, what's important is for both types of cancers. What's important is knowing what the risk factors are, knowing about some of the diagnostic studies or tests that are done, because then they're unique, right? Some of the testing is unique. And let's see what else. Some of the treatment is the same. So if we're talking about things like radiation, chemotherapy, that we've tackled already, right? So now we'll probably highlight things like what is a hysterectomy, let's say. Stuff like that may be new for you, but the other pieces of information are definitely not going to be that different. Anyway, so we'll go along and see what you need to kind of focus on. All right, so here we're talking about pathophysiology, clinical manifestations, and collaborative care of cancers of the female reproductive system. So we have a lot of stats surrounding cervical cancer here. So let me just put all of them up and then I'll talk about them. All right, so it's a major cause of cancer death in women and in many developing countries. So especially in developing countries now, there's a lot of decreased detection. Hopefully that's changing. I know like at one point in my country it was like #1 among women, the cervical cancer was, and it was a really, really big deal. And I wasn't even sure how, why, maybe before we went testing and we didn't know. But I mean, I don't remember women dying from cervical cancer, and I would think that they would have had manifestations, right? But for some weird reason, at one point, there was like a lot of women in my country that were getting cervical cancer. So there was a lot of research that was done and continues to be done to kind of stop all of this. So you will see that there's certain types of cancers that are more prevalent in different parts of the world. So third most common reproductive cancer, more than 12,000 per year diagnosed in the U.S. And once again, I don't need you to remember stats at all. The main thing that I am highlighting, though, is the prevention. So prevention is key. And so you want to make sure that we're catching these cancers as early as we possibly can. So what are we doing? So we're doing regular pelvic exams, Pap tests for all women, especially older women past childbearing age. So for nurses in particular, when you start getting patients, or even before you get patients, let's say you're in the community health setting, a lot of what you're going to be doing is going to be centered around education. So you want to tell young women and men even, to delay sex, basically, because that could impact, their girlfriend in a negative way. So let's say, teach delaying of sex, avoiding HPV infections, engaging in safe sex, condom usage, ceasing smoking, and getting the HPV immunization. happens. And I'm pretty sure you've seen the commercials on TV that specifically talk about young people getting HPV immunization. So the risk factors, the page is on 1706. So some of the risk factors are in the slide, but I also want you to look at the chart as well. All right, so in terms of your risk factors, so HPV for sure, number of sexual partners, as the more sexually active you are with the more partners, the worse it can be for you. Use of condoms, HPV vaccination, regular smear tests need to be done. There is a vaccine known as Gardasil, which apparently can help protect against infection with HPV subtypes 16 and 18, as well as subtype 6 and 11. All right, so this is a vaccination that basically we're promoting right now. Key thing about the vaccine is that it's used to prevent HPV infection. It does not help or treat an existing infection. So that's important for the nurses to teach their patients. So of course there's some cultural implications for this. So just like in some parts of the world, if you're trying to teach young people safe sex measures and you tell them to use condoms, right? Because we all know that young people are most likely going to have sex, right? But you come across cultural implications, because then people get upset that you're promoting children to have sex because you're telling them to use condoms. So it's the same type of thing with the vaccine. Some people may feel that if you're telling people to get the vaccine, that you're basically promoting that they should have sex, right? When really you're trying to say, get this HPV vaccine because we know that young people are going to have sex. They may pretend they're not, but they are. So anyway, that's a cultural piece that nurses have to deal with, and they have to be culturally sensitive when they're educating different cultures. Or even, actually just regular people even here, maybe they're extremely Christian, so it doesn't have to be like from a whole different part of the world either. All right, so in terms of the anatomy here, so we know that the cervix connects the body of the uterus to the vagina, right? So this is a good time to kind of look at some pictures if you're not familiar with anatomy, because it does matter, especially for this part of the lecture. So cervix connects the body of the uterus to the vagina. The cervix is the lower part of the uterus. So cervix is the lower part of the uterus. And I'm hoping you've had all of this already anyway, because you've done OB. The part of the cervix is closest to the body of the uterus is called the endocervix, and the part next to the vagina is the exocervix. So there are two pieces that are important to remember. So endocervix, closest to the uterus, and then the exocervix, closest to the vagina. And then there's another piece basically that's like in between those two, like the endocervix and the exocervix. There's a border inside that's deeper, and that part is known as the transformation zone. And that's the part that's really, really hard to get to. And that's the part where a lot of cancers actually can be found. But when they're that deep inside, it's hard to find them. So that's why for those types of cancers that are deep inside in the transformation zone, they have to do a curettage. They have to go in there and scrape some tissues out and to be able to actually look at it closely. So we'll talk about that later on as well. So endocervix is important to remember, as well as exocervix or ectocervix. So notice that for the outer, you can either say exocervix or ectocervix, ECTO cervix. Many different types of cervical cancers, so squamous cell carcinomas, adenocarcinomas, and then adenosquamous carcinoma, so many, many different types. So here you just have the same thing we're just talking about. So you've got your uterus here, closest to the cervix, so that's your endocervix, and then you've got your vagina here. So at the bottom piece here is the exocervix, and somewhere in between, like the endo and the exo, somewhere deep in there would be your transformation zone. So this is someone looking at cervical cancer through a speculum. that's been inserted into the vagina. So that's pretty ghastly. Yeah. So the change from pre-cervical, from cervical precancer to cervical cancer usually takes several years, but it can happen in less than a year. So that's the trick, because if the cancer is inside where they can't see it, and sometimes you're not getting any symptoms right away, it takes time for it to build up, right? So sometimes, women will find out they have cervical cancer just because we're getting weird discharges, but then they did not necessarily have like any weird specific symptoms at all. But all of a sudden, maybe they're having pain on intercourse, they're getting this weird discharge, foul discharge, things like that, right? So just know that the progression and the detection can take time. So for most women, precancerous cells will go away without any treatment. So that would be great. So remember, our immune systems are always protecting us. So we have the capacity to fight off precancerous cells. Like, that's a true statement. But depending on how advanced the cancer is, how strong the cancer is, and how strong our immune system is, all of those factors come into play. And then also, are you smoking? Are you drinking? Like, there's just so many variables, right, as to why one person would end up with cancer versus another person won't, given everything being the same, right? So it depends on how the patient reacts to stress, even just all those different components you have to think about. So these cells do not suddenly change into cancer. The normal cells of the cervix first gradually develop precancerous changes that turn into cancer. And there are two main types of cancer cells, so squamous cell carcinomas and adenocarcinomas. So apparently 80 to 90% of them are squamous cell carcinomas. All right. So anyway, in terms of detection, you really have to make sure that we're paying attention to the risk factors and minimizing the risk factors, so that we're giving our client a fighting chance that they will not end up with cervical cancer. All right. So women with early cervical cancers and precancers usually have no symptoms. So early signs usually ignored, but may see things like thin, watery vaginal drainage, especially after douching or intercourse. So the recommendation is that we shouldn't even necessarily be douching so much as women, because when you do that, sometimes you change the normal chemical flora that's there for your protection. I know that there's some women that believe in douching like every week or every day, and that may not necessarily be the best thing. So that comes under teaching for your patients as well as a nurse. You want to make sure that they know that, okay, if you're going to douche, fine, do it maybe after menstrual periods or something like that, but it's not something that you want to be doing all the time. But anyway, it is important for you to kind of be familiar with some of your early versus late signs. So early here, we've already mentioned that they're usually ignored, but sometimes your patient can see very thin, watery vaginal drainage. In the advanced, you're going to be seeing more of that vaginal discharge, right? Now it's dark. It's foul because of cell necrosis and infections. Also, you're getting things like leg pain, dysuria, rectal bleeding. You're getting things like edema of extremities, bleeding after vaginal intercourse, bleeding after menopause, bleeding and spotting between periods, having menstrual periods that are longer or heavier than usual, and just really unusual discharge from the vagina. So you want to kind of make sure that your patients, from the time women start maturing, getting the periods, that they really understand how their body looks under normal circumstances, so that they will be able to detect if anything changes, right? If anything different is going on. So no one should be ignoring the fact that maybe they weren't having pain during intercourse before, right? Normally there's no pain, and then all of a sudden everything is painful. Like, that's something that should be alarming, and the patient should definitely want to investigate that further. Right. Your diagnostic studies. So what are we doing here? So these are recommendations essentially. So in terms of doing your diagnostic studies, right, they want you to start some of these tests within 3 years of being sexually active, right? Then we kind of want to start monitoring the young lady, right? So if your child is going to start having sex like at the age of 15, right? I know that's like parents out there having panic attacks right now, but let's say your child, is going to start having sex early. So at 15, so 15, 16, 17, 18. So that young lady, you're going to want them to start diagnostic studies or testing for them. Um, or if they're, not doing any of that, they didn't start being sexually active early, at least by the time they're 21, you kind of want to start doing diagnostic studies on them. So what are some of our diagnostic testing that we can do? So we have a pap test, which is getting scrapings from the cervix. We have things known as colposcopy. We have cervical biopsies, so endocervical curettage, colposcopic biopsies, and cone biopsies. So these slides have notes in them to kind of help you understand what some of these things mean. So what you want to do is when you pull up the slide, I think when you're trying to print it, you can say print with notes, and then that way you get the notes. Or because sometimes if you do that, the print will be too small. You can also just pull up the slide and then go underneath the whichever slide you're looking at, just go underneath that slide, highlight all the whatever is written, and then put them in a separate Word document. So then that's easy for you. All right. So underneath these particular slide right now, there's some notes there that are important to know. So let me just go over some of them. So in terms of the pap test, so this is just a screening test. It's not a diagnostic test. It's a screening test. Like we're looking for stuff, right? So an abnormal pap test result may mean more testing is needed, right? So we are using the pap test for screening, all right? The colposcopy, so anytime you see scope there, you know that they're looking around, right? So they're examining the cervix. They have a magnifying lens there, and they're basically looking at the cervix very closely. They use a weak solution of acetic acid. They apply it to cervix so that they can see any abnormal areas closely. They can also do what is known as a colposcopic biopsy. So in that case, they're going to scrape off some of the they use biopsy forceps rather, and they'll basically take off some of that tissue, and then they're going to look at it. After that biopsy has been done, the patient can have mild cramping, brief pain, and some slight bleeding afterwards. So for the biopsy, they're also going to use like a local anesthetic in some cases to numb the cervix before they do the biopsy. For the biopsies, so they may describe them differently. So I mentioned the colposcopic biopsy already. They can do what is known as an endocervical curettage. So for this one, they're doing endocervical scraping. So they're trying to get inside to the transformation zone, which is the risk area, right? So they're scraping some of the tissue, and then they're sending it to a laboratory for examination. So same thing, cramping, pain, and some light bleeding. So that's part of your teaching. And then for the cone biopsy, so the other word that they may use for this one is conization, conization. So they're basically taking out a cone-shaped piece of tissue from the cervix. So cone biopsy, think cone-shaped piece. So the base of the cone apparently is the exocervix, and then the apex of the cone is the endocervix. So they're just cutting out a piece from there. So it's shaped like a cone, essentially, is what they're getting at. So in some cases, when they do a cone biopsy, that is the treatment, because when they've taken that out, they've taken out the cancerous tissue, and that may be enough for some patients. In some cases, they're just using it basically for further studying to see whether or not there is cancer and whether or not, if it's advanced in any way. So having a cone biopsy will not prevent most women from getting pregnant. But if a large amount of tissue has been removed, women may have a higher risk of giving birth prematurely. All right, so in terms of your pap testing, so always keep in mind that these are just recommendations. So we have these are recommendations, and obviously if there's a history of cervical cancer in your family, those testing parameters may be adjusted, although may vary slightly. So ideally, women who are sexually active and over the age of 21 to have pap testing. Women between the ages of 21 and 29, they want them to be tested at least every 3 years, because by the time you're 21 to 29, you're most likely sexually active. So that's a high risk category there. So you want to make sure we're testing. Women between the ages of 30 and 65 should have a pap test plus an HPV test every 5 years. Women over age 65 who have had regular cervical cancer testing with normal results should not be tested for cervical cancer. Right? So if you've been normal over 65 and your testing has been normal, they're thinking that, okay, you're pretty okay. Before the procedure, they don't want you to douche. And then obviously there's a careful menstrual and gynecology history, right? And this is all American Cancer Society guidelines. So we have additional testing for larger tumors, okay? So they can do things like a cystoscopy. So once again, there are notes underneath this that you can look at. So with the cystoscopy, so obviously you have a lens here. We're going into the bladder through the urethra, and you check your bladder and urethra to see if cancer is growing in those areas. And with that, you can also do a biopsy if needed during the cystoscopy. A proctoscopy is a visual inspection of the rectum, once again to look for if any of the cancer has spread to the rectum. Let's see. So here you can also do imaging studies like MRIs, CAT scans, chest X-rays, etc. So a pelvic examination under anesthesia may also be indicated to find out if the cancer has spread beyond the cervix. So if they really need to go in there further, they may have to do that as well. So just know that these are out there. All right, so we don't do stats. These are old anyway. All right, so your medical management, precursor lesions. So what are we going to do in terms of medical management? So there's a lot of things, and we'll kind of talk about these a little bit more as we go along. So for precursor lesions, before they definitely become like metastasized and really advanced cancer, hopefully we can just do conservative treatment, or we can do things like cryotherapy. So cryotherapy is freezing with liquid nitrogen or laser surgery, right? If it's an invasive cancer, then we're gonna have to see what we have to do for them. So it depends on the stage, the health of the patient, all that good stuff. So maybe surgery or radiation. So you can look at chart 57-7 for some of these things here. So 2 years after surgery, recurrence is high, often in the upper quarter of the vagina. So if you're seeing things like weight loss, leg edema, pelvic pain, all of this may be signs of lymphatic obstruction or metastases. Other treatments, radiation, either external, beam, or brachytherapy. So we've discussed these already. And some of the things you're looking for are things like vaginal stenosis. Apparently this is a frequent side effect of radiation. So that's pretty horrible as well. Right. So then you're going to highlight all your notes, and then you can look at what each of these surgical treatments looks like. So for the cryosurgery, we already said it's liquid nitrogen, it's placed on the cervix, and then you're basically freezing the abnormal cells. You may have a lot of watery brown discharge for a few weeks after this particular procedure. And they usually do this for precancers of the cervix, like at stage 0, but they're not invasive, right? so the lower end of the cancer spectrum. So they see the cancer is there, but it's usually like tiny. For the laser surgery, so think burning off, think vaporizing, so of the abnormal cells. So they have local anesthesia there given, and this one is also not for invasive types of cancers. And then conization, we've mentioned already how this is done. So it can be, that can be the treatment itself, or it can be used as a diagnostic measure to see, okay, how advanced is the tumor itself. For hysterectomies, so with the hysterectomies, know that there are different types of hysterectomies. So they can be considered just simple, or really the major one we talk about is simple versus radical. That's what we usually talk about. So if it's simple, they're usually just saying the uterus and the cervix has been taken out. If they're calling it radical, usually they're meaning uterus, cervix, and other tissues, and they will usually describe what those other tissues are. And then for the trachelectomy, so for that, the cervix and upper part of the vagina basically is being taken out, but they're leaving the uterus in so that the patient can potentially have a baby. So for the trachelectomy, cervix and upper part of the vagina taken out, but not the uterus, so that they can potentially have a baby. And then they do some, surgical reconstructions and all of that to make all of this work for the patient. All right, so let's see. And then with the hysterectomies, so just know that there are different ways they can do these. It can either be abdominal hysterectomies. That's when they're doing it, the incision in front of the abdomen. If they're taking the uterus out through the vagina, they may call that vaginal hysterectomy. Well, that's exactly what they'll call it, vaginal hysterectomy. If they're taking the uterus using a laparoscope, they'll call that a laparoscopic hysterectomy. So just, know that this terminology is out there. The idea is that recovery time is usually shorter for laparoscopic or vaginal hysterectomy than for the abdominal hysterectomy. So those are just some other things. So I need you to just look at some of the notes that I have for you. Let's see, under the radical hysterectomy, so here they're removing uterus along with tissues next to the uterus. They're describing them as the parametria and the uterosacral ligaments. Let's see, they may also take out ovaries and fallopian tubes if needed. There's also a chart in your book up on page 1707. So surgical procedures for cervical cancer. So those notes are a little bit shorter as well. Let's see. So more tissues removed in a radical hysterectomy than in a simple one. So the hospital stay can be longer, even as much as 5 to 7 days. Uterus is removed, so surgery results in infertility. So complications, unusual, but could include things like excessive bleeding, wound infection, or damage to urinary and intestinal systems. So sexual impact of radical hysterectomy. Radical hysterectomy does not change a woman's ability to feel sexual pleasure. So that's important for the patient to know. So you want to make sure that they're aware of that. And then for the trachelectomy, so we mentioned that already. So this is where they're removing cervix and upper part of the vagina, but not the body of the uterus. And then they do some reconstructive surgery there, where they have like a purse string, is what they called it, so that the patient may potentially still have a baby. Let's see, for the pelvic exenteration, so these are really crazy words. Anyway, so this is used to treat recurrent cervical cancer. So all of the same organs or tissues are removed as in a radical hysterectomy. But here you may have also pelvic lymph node dissection. So now they're excising some of the lymph nodes because obviously the cancer has metastasized, has spread. So in addition, bladder, vagina, rectum, and part of the colon may also be removed. So what are the implications for that? So if the bladder is removed, obviously you're going to need a urostomy. If the rectum is removed or part of the colon is removed, you're going to need things like colostomies, right? So just know that this is a much more advanced type of surgery. And of course, if the cancer has metastasized, that's why they're doing the pelvic node dissection, potentially with a pelvic exenteration. So then they're like cutting off some of that lymph nodes where the cancer has spread to. All right, so this is just some terminology that I would like you to be loosely familiar with. And like I said, there are notes for you to look at